name's Kaylee. I'm going to show insertion and irrigation of an NG tube. So before I go in the patient's room, I'm going to check the doctor's orders. He wants an NG tube placed for suction, so we're going to use the NG tube for suction. So I'm going into my patient's room, explain to him quickly what I'm going to do, and I'm going to check his mirrors for patency. So they looks good. So I'm going to have him occlude one side and breathe in, and then the other, and select the one that seems to have the most airflow, which to me is the right. So we're going to go into the right side. So I'm going to measure my tube length from the nose to the ear, the xiphoid process, and mark it with some tape. And I'm going to apply my gloves. And lubricate up to 4 inches at the distal end of my tube. About 4 inches of it. And I'm going to let the client know that I'm about to start advancing the tube. I'm going to advance with the curved end pointing down. Don't feel any resistance, so I'm going to check for coiling in the back of the throat. There's no coiling. So now I'm going to have him tilt his head forward. I was having him tilt it back earlier. Forward and take small sips of water. Every time he swallows, I'm going to advance until I can go, and I would advance it all the way to the tape. Then I'm going to temporarily tape it to his cheek while I verify placement. So to verify placement, I'm going to have him talk so that he's not coughing, gagging, he can talk without problem. Then I'm going to inject 30 cc's of air while I listen over the abdomen for bowel sounds to confirm that it's placed in the abdomen.
So, yeah, you attach, hang it, label the tube, then prime the chamber and prime the
Okay. So I observed a motion sound. So it's placed in the abdomen. I'm going to aspirate a small amount of gastric content and check the pH. So I want it to be less than 4, or whatever the hospital's policies are. And the hospital might have me do an x-ray to verify placement, finally. So once I'm sure it's in place, I'm going to tape it down more securely to his nose. Then I'm going to fasten it to his gown so that he doesn't accidentally pull it. So I'm just going to safety pin it to his gown.
So just be like,
So now it's secured to him, so I'm going to attach it per the doctor's orders to low intermittent suction, and note the color, consistency, and amount of the drainage, the time I inserted it, how he tolerated it, and I'm going to measure the length of exposed tubing. So now it's on suction. I'm going to be able to leave the room. I would discard my glove. Then the doctor orders that we flush the line. So I come back in and apply clean gloves. So I'm going to get a towel and disconnect it from my suction. Set it on the towel. And I'm going to confirm placement, see if I can aspirate 30 cc's of gastric content. And I do, and then I'm going to listen while I push it back in to make sure we're still in the abdomen, or the stomach. Okay. So we still have our placement. I'm going to drop 30 milliliters of water to irrigate with. And I'm going to push the 30 in, and I'm going to draw 30 out. Realize it looks like gastric contents, and I'm going to discard my 30. And since we're still patent, I'm going to reconnect it to my low intermittent suction as the doctor ordered. Take off my gloves, and I'm going to go document that the NG tube was irrigated. I put in 30 milliliters of water. I drew out 30 milliliters of gastric content and discarded, and he tolerated it really well, so we're going to leave it running.